Good evening, everyone. Thank you for joining us for the IDF Forum, Immune System Basics and Primary Immunodeficiency. I'm Kathy Antela, Vice President of Education at the Immunodeficiency Foundation, and I'll be your MC tonight. So on behalf of all of us at the Immunodeficiency Foundation, welcome, and not only welcome, but Happy New Year. We are so very glad you have joined us this evening. And at this time, I am so honored and excited to introduce IDF's new President and CEO, Jory Berry, to you. Jory, take it away.
Thank you for that warm introduction, Kathy. Well, let me welcome you to the first IDF Forum of 2022. It is hard to believe, but we've now been hosting these online forums for 2 full years. And in that time, we have facilitated more than 100 of these events and hosted more than 10,000 participants. I could not think of a better way to spend day 4 in my new role than to be with all of you, the heart of our organization and the reason we exist. After only 4 days on the job, even I know that. Because I haven't had a chance to meet many of you yet, I'd like to tell you a little bit about myself. I've spent the last 20 years at another national nonprofit, the March of Dimes, where I had the opportunity to develop really deep understanding and experience across many facets of an organization that's very similar to IDF. Whether it was advocacy and public policy or volunteer development, fundraising, or even staff development, at the center of it all was a strategic vision built on a steadfast commitment to the mission and to the people we served. Before March of Dimes, I worked in government affairs, and right out of college for about 2 years, I was an English teacher. My husband and I have one son who's 23 and in graduate school, and I live in Texas. I don't know if you could already tell that. My apologies. I can't hide my accent as much as I try. So while it's my first week on the IDF team as president and CEO, I can tell you that I'm already immensely impressed by the dedication of the IDF community. It is very clear to me that I am joining an organization with a strong legacy, and I plan to help foster and continue the good work that all of you are already helping to accomplish. Our mission to improve the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research forms the very foundation of our work. We have a bold vision for the next 5 years, and I'd like to share that with you now. IDF seeks to ensure that everyone in the U.S. affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all of their opportunities for connection and support within the PI community. Over the next 5 years, with your help, we have the audacious goal to shorten the time to diagnosis and treatment, to raise awareness of PI, and to take action to remove health disparities. IDF is made up of a strong team of dedicated professionals who are going to seamlessly carry on our work to keep the organization strong and ensure success in our mission. A mission to support people whose lives have been impacted by PI. We look forward to an exciting year ahead, including some of IDF's most important initiatives. In the weeks to come, you'll hear more about how we move forward with some of those really audacious goals, like the Primary Immunodeficiency Conference and its hybrid approach for 2022, a reimagined walk program, and growth in our advocacy and research initiatives. Online events provide additional opportunities for accessibility and connection that just really weren't possible when we held the event in person alone. So both modalities offer new possibilities for growth and inclusion. And as we ease back into some limited in-person engagement, we can take the best of what we've learned over the last 2 years of virtual event hosting and apply it to in-person and hybrid programs. We have an awesome responsibility at IDF. And I mean awesome in the impressive and daunting sense of the word, maybe not how I used it in the 80s. I personally, and I know this, I have a lot of listening and learning to do, and you play a critical role in that. We know that the voices of caregivers and patients with PI tell an important story. In fact, IDF was born out of a need voiced by parents for a patient advocacy organization to support those with PI conditions more than 40 years ago. We are on the path to an even brighter future together. Thank you.
Thank you so much, Jory. All of us look forward to having you join us in the PI community and on that path toward a brighter future. Thank you so much. And with that, the typical disclaimer before our presenter starts tonight is that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified healthcare provider with questions concerning a medical condition. So at this time, I would like to introduce our presenter. So Dr. Hey Chong is an associate professor of pediatrics at the University of Pittsburgh School of Medicine and is board certified in allergy and immunology and practices at UPMC Children's Hospital of Pittsburgh. In 2013, Dr. Chong started the primary immunodeficiency clinic, where she is now the division director of allergy and immunology. Her academic interests lie in the care of patients with inborn errors of immunity and creating a multidisciplinary approach to the management and treatment of patients with both primary and secondary causes of immune deficiency, which is the key focus of the immune dysregulation diagnosis and treatment program, which she directs along with faculty across several divisions, including bone marrow transplant, gastroenterology, rheumatology, and infectious disease. So at this time, please join me in welcoming Dr. Hey Chong.
Hi, thank you very much for that very kind introduction. And I am honored to give the first talk of the year. I was asked to speak about our amazing immune system and talk a little bit about what can go wrong. I made 60 slides for my 20-minute time slot, so I might be skipping over a few of these, but you're more than welcome to look through and ask me some questions. And at the end, if you see something that I glossed over that you would like to know more about, I'm going to try to make this as very general, but with the understanding that there are definitely many times in my life that I've encountered a patient who is more knowledgeable than I am sometimes about certain aspects of their disease process. So don't get offended if I make it too basic, but I just want to start it off as basic as possible. So the basic outline of today is, what is the immune system? What can go wrong? And maybe just a little bit about what can we do about it. So I think it's so interesting that in 1970, a group of really smart doctors got together from the World Health Organization, and they reported a whopping 16 primary immunodeficiencies. And then in 2017, they reported so many more than that. 320 different primary immunodeficiencies in 9 different categories. And now there's over 450, and I think that's a low estimate. Look, not just at your immune system in your labs, we can look at your genes, lots and lots of genes, all at the same time. We've been able to discover lots of new immune defects that cause different types of immune deficiency. And it's actually taught us a lot about how the immune system works to find these gene defects in the immune system. So actually in all of my talks that I give to the medical students, to the residents, to the fellows, I actually have been using this slide for the last 10 years. And that's because we're always taught to think horses, not zebras, right? So just think of what is most common when you hear the hoofbeats. But what I love about my job is that I get to sit around and think about the zebras. I always say that it's the closest to playing house that I can get. Like that TV show, because I could just sit there. I've literally looked at hair under a microscope. I've literally looked at my own, at someone's blood on a slide. There's not a lot of medicine where you get to really just look really hard at each individual patient. So just to talk about the immune system in general, we always think about the cells in the immune system, but your immune system is really more complicated than that. So when we think about the immune system, it's actually really just a complex network. There's just the cells, the tissues, the organs. These all work together to help defend your body against foreign invasion, which is just what we like to collectively call pathogens. So those are the bacteria, the viruses, the fungi, parasites. So the immune system is complex, so it's sometimes helpful to divide it up into different types of immune system. So first I want to talk about the innate immune system, and that is innate. You're born with it. It's your defense from birth. It is the most ancient immune system. And in fact, us lucky vertebrates have an adaptive immune system, but every other organism, even plants actually, have an innate immune system. Worms have an innate immune system. So this is just a very non-specific, fast-acting, can occur within minutes or hours, where you have a defense against pathogens. So the first part of your innate immune system is going to be your physical barriers. And then there's also a lot of other defense mechanisms and general immune responses in cells. So that's the complement system, and as well as the immune cells. But even something as simple as your skin, which is your largest organ, right? That's a great barrier from microorganisms. So having a cut in your skin is really how some of these pathogens can enter into your body and your bloodstream. Tears are great for protecting your eyes. Saliva is very important in protecting your mucous membranes. And even mucus in moderation when you don't have too much mucus. But mucus is really great at preventing bacteria from really sticking to the back of your throat and working its way right in there. That mucus kind of the bacteria falls on the mucus and you clear it out. And that is the beauty of mucus. I've never really said that's the beauty of mucus before. So other parts of your immune system is your complement system. And this is also part of this ancient immune system, where I think it's really cool because it's comprised of all of these proteins that work together in this super complicated cascade. And the only reason I show this picture is to tell you that we have to memorize this sometimes for our boards, and it's so complicated. These weren't even named. There's C1, 2, 3, 4, and they weren't even named in the order of how they work, but really kind of in the order of discovery. So it makes it a little bit confusing at times, but what they do, which is just amazing, is that they can just set one off after another, where they activate one, cleave and activate the next piece, so that they work together and they can literally form what looks like a little chimney that just punches a hole right into the microorganism. And that's just amazing. The other thing about the complement system is that it actually helps your antibodies do their job, and antibodies is a part of your adaptive immune system. So this kind of can cross that bridge between your innate immune system and your acquired/adaptive immune system. And I'm not going to talk a lot about deficiencies in complement, but there are so many described immune deficiencies. Some of the earlier ones, like C1 inhibitor, can lead to hereditary angioedema, if you've heard of that. There's people, I take care of with C2 deficiency, which is just one part of the complement cascade. There are people that have what you see here on the terminal pathway with defects in C6, C7, C8, and they specifically get the other aspects of your innate immunity are just phagocytes. So that's just a fancy word that means cells that eat. And that's really literally how they work. They just kind of eat, they engulf, they kill microorganisms. And then sometimes they send out this cytokine. So what are cytokines? You've probably heard of the word cytokines, but that's really just a cell signal. It's the way cells communicate with each other across distance is with cytokines. It can attract other cells. It can tell cells what to do. It can activate another cell. So cytokines are really important. And so when we think of phagocytes, we think of neutrophils. Neutrophils are what you see on your CBC every time your doctor gets a CBC, a complete blood count, and you look at white cells. Those white cells are mainly comprised of neutrophils. You make billions of them every day. Other aspects of your innate immunity are NK cells. And this is what's confusing because NK cells are technically lymphocytes, but they're actually part of your innate immunity because they don't learn like the other lymphocytes do. And NK cells actually have a lot of important jobs. They can suppress graft versus host disease. They can kill cancer cells. So there's a lot of research about NK cells in cancer treatments, but they also kill viruses. And that's why this is important for our discussion today. NK cell deficiencies are actually pretty rare to have just an NK cell deficiency, but it's not rare to be NK cell deficient as a part of another immune deficiency. But what we do know from patients who have an NK cell deficiency is that they must be really important in fighting specific herpes viruses. And that's a family of viruses that include varicella, herpes, EBV, so that's Epstein-Barr, and CMV, cytomegalovirus. And even some patients with an NK cell deficiency can get really bad HPV, which is human papillomavirus. So moving on to the smart part of your immune system, and I've tried to write down words that you might hear. Some people call it the adaptive. You can be called the acquired immune system. They're kind of interchangeable from the way we're using it, but it's really the part of your immune system that learns over time. And that's either through infection or vaccination. So your immune system learns to get faster and better. And that's one thing I like to talk to my patients about is that that's really the point of vaccination, is so that the adaptive immune system, it learns, it takes time. It's not going to kill microorganisms right away like a neutrophil can, right? So if you come in contact with tetanus the first time, your body's going to be like, oh, what is this? I don't like this very much. And your immune system will activate and you'll start making antibodies, but it's going to take days, maybe even it's going to take weeks possibly. And by then the tetanus has just wreaked havoc on you, right? You could be intubated, paralyzed, not able to breathe. But because you're vaccinated, your immune system learns to recognize it, right? So you get vaccinated, your antigen presenting cells take it up and they run around and they're like, look at this T cell, what is this? This is bad, we don't like it, right? And the T cell is gonna send a signal to the B cell and say, B cell, make some antibodies, like this is no good. And then when you're the tetanus from the vaccine, over time, that part of your immune system is gonna quiet down, but it's there, it's waiting to encounter tetanus again. So the second time, if you step on that rusty nail, right, your body is like, I know what this is. I totally recognize this. And you're going to have an immune system response. Your immune system is going to know what to do within days, right? Not weeks. And that's really what's important about vaccination and the adaptive acquired immune system. So the cells that are important in your adaptive immune system are the lymphocytes. Well, specifically these lymphocytes, because I told you not all lymphocytes are part of the adaptive immune system, but T cells, there's so many types of T cells, so many. But the ones I'm going to talk about probably the most, just for simplicity, are CD4 and CD8 T cells, and CD4 considered like the T helper cells. And they got pretty famous from HIV because HIV, when it came out, they specifically infected CD4 T cells. And a lot, actually, of what we know about what CD4 T cells do and what happens when they get very low, a lot of that is from HIV, which was very specifically targeting CD4 T cells. CD8 T cells are cytotoxic. That's what they're called, cytotoxic T cells. And they also help in fighting viruses. The other lymphocytes that are really important are your B cells. And that's important because they are important because they make antibodies. And that's that type of immune system within adaptive immunity is called your humoral immunity. So when you hear that, you're thinking B cells and antibodies, which is under adaptive. So this is T cells. These are not real T cells, these are drawings of T cells. So the T cell progenitors start in the bone marrow and they migrate to the thymus. That's really what the T in T cells come from, is that's where they learn to be grown-up T cells in your thymus. And these are some more the T cells that I listed: CD4, regulatory T cells. There's more T cells than orchestrate the immune system as well. So the thing about T cells is that they're actually critical in telling B cells what to do, just like we discussed about the vaccines. So if you have a T cell defect, you're going to not have B cells making antibodies either. In some cases, if you have no T cell function. B cells. So the B, you would think is named for bone marrow because that's where they develop, but it's actually named for bursa, which we don't have as humans. I think they're in birds. So let's just pretend that the B is for bone marrow to help you remember where they mature. And they are responsible for our humoral immunity, and they make antibodies. And so the antibodies you've probably heard of: IgG, IgA, IgM, IgE, IgD, you probably haven't heard of as much because it's not secreted. But IgG also has subclasses. IgA also has subclasses. We don't check those as much. But sometimes we call them immunoglobulins. You might hear that. Sometimes we call them antibodies. I feel like how we have different names for the same things is very confusing. So I'm going to try to use all of the names that I hear for these different things. But the antibodies are usually composed of 2 heavy and 2 light chains. I think this is probably too specific, so I'll skip over. But the isotype is determined by the heavy chain, and I think that's important because this kind of tells you additional functions to the immunoglobulins, which I have here. So IgM is one thing that's interesting about IgM is that when it's secreted in your blood, it's a pentamer. What's that mean? That IgMs don't like to float around by themselves. They like to float around in groups of 5. So they're huge. They're much bigger than your other immunoglobulins. The IgD is bound to naive B cell membranes, and then very trace amounts are secreted. We don't really measure that in the blood very much. IgG is actually the majority of your antibodies that are fighting infection. The reason you get vaccinated so you can make IgG. They're great at binding complement. They are great at taking up bacteria, and IgG crosses the placenta. So that is what the mom is able to give the baby in utero. So in fact, the first 2-3 months of a newborn's life, when you're measuring that newborn's IgG, you're measuring mom's IgG because that newborn didn't make it. But the IgM, huge. That IgM, when that baby has IgM, that baby made that IgM. That IgM did not come from the mom. The other reason I mentioned the sizes, honestly, is because sometimes I'm in a situation where somebody's asking me, is this patient not making antibodies, or is this patient losing their antibodies, right? And one of the big hints for me, if someone has a reason why they would lose, is what's their IgM. So if their IgG is low and their IgM is stone cold normal, then it's possible that they're losing it because IgG is smaller to lose. It's a monomer, it hangs out by itself, but IgM is a pentamer like we discussed. So it's really difficult to lose IgM. So if someone says, oh no, their antibodies are low because they have a kidney issue, but their IgM's low, I say, no, there's something else wrong. They're not just losing their antibodies. They're not making antibodies. IgA is secreted as a monomer. It could be a dimer. Usually it's a dimer. But this is important because it's in breast milk, and it's important in mucosal immunity. So some patients who don't make good IgA, they get more sinus infections and can have lung infections. And then IgE, as an allergist as well as an immunologist, I think about a lot. And what is it good for? So it's actually good at fighting parasites, but we don't really get a lot of parasitic infections anymore in the US. So now it just bothers us and causes allergies. So the inborn errors of immunity. How do we know? When do we get suspicious that someone has an inborn error of immunity? So this is on the left, it's these great posters from IDF where it says, is it just an infection? Is it severe? Is it persistent? Is it unusual? Is it recurrent? Does it run in the family? I like this because this really hits all of the key points. The one on the right is from Jeffrey Modell Foundation. And some of these, especially honestly, 6, 7, 8, 9, 10, those really help us think about immune deficiency. And when you look at the USID net, where we, and I think patients as well, can input different types of immune system issues that patients have, you can see that the vast majority of immunodeficiencies are antibody defects. So I am going to spend some time talking about that. So just to go over some of the warning signs of immune deficiency, one of the big warning signs is when something mild presents in a life-threatening manner, or it just happens over and over and over. And so I'm doing some of these cases that I've seen here at the hospital. And one of our cases, 4-month-old, who had CMV pneumonitis. So CMV can infect newborns. That's not too unusual, a little old for that. And then they had a bit of an O2 requirement, but what happened is they did not clear their CMV. And when I saw them back, they had an even higher CMV titer. She also had some facial features that just really did not look like either of her parents. She had no NK cell function at all when I checked. She had really low lymphocyte counts. And we ended up sending genetic testing, and she ended up diagnosed with something very rare called ICF2 syndrome, which is immunodeficiency, centromeric instability, and facial anomalies type 2 syndrome, with a pathogenic variant in this gene. So infants and adults with HSV1 encephalitis, especially maybe not just once, but maybe more than once, can have TLR3 defects. 6% of patients with HSV1 encephalitis can have TLR3 defects, and they're going to get it again. And if you see that, you know you need to prophylax them so they don't get it again. And abnormal immune responses to EBV leading to HLH. So EBV should cause mono in patients, and mono's not fun, but patients clear mono. But when you have EBV causing all kinds of other things, or very serious things, like HLH, you really start to wonder if there's something else going on. And those patients may have an XIAP deficiency, and the X is X-linked. So this is something when we see EBV leading to HLH, we think about XLP. So other warning signs, blood counts are low or persistently high. And so another patient we had, 2-year-old, had some seizures, developmental delay. They had, when they came to see me in clinic, actually it was because they had high allergy cells and was concerned about weed allergy. But what I noticed is that in the past 2 years of this child's life, their lymphocyte count was never normal, not once. Every single lab that had ever been done, this child's lymphocyte count was extremely low. If we're talking 2,000 being normal, this child's lymphocyte count was never higher than 200. And that patient ended up, we diagnosed with something very rare called purine nucleoside phosphorylase deficiency, PNP deficiency, and that patient's been transplanted. We have a teenager who was referred for elevated inflammatory markers, so referred to me from rheumatology. They had really high platelet count, which sometimes your platelet count can be high if you have an inflammatory, if you're inflamed for some reason. And what's interesting is this teenager had had a big spleen multiple times, was told that maybe it was mono, but it just never really went away. And so when I mentioned that, the dad was like, it's not even a big deal because I have a big spleen and so does my dad. And then I realized, well, that means 3 generations of this family have a big spleen. That can't be coincidence. And so that patient actually ended up getting diagnosed with autoimmune lymphoproliferative syndrome. So I think this is an example where the blood counts being persistently elevated made rheumatology refer them to us, and a good family history made us realize that this is likely genetic. So that's the other point. Family history is super important. Certain types of, if the family history, there's history of infection, it's what's really sad is if you have, I always ask about sudden infant death syndrome. There's cases of missed skid where family members had what was thought to be sudden infant death. If there's a lot of cancer in the family, I'm suspicious that there's something genetic going on, especially cancer in family members, both sides who are young. If there's a lot of autoimmunity in the family, that automatically will raise my suspicion level. And consanguinity is a fancy word for having parents that are genetically related. There's a lot of physical exam features that can make you suspicious. Most of these are from a textbook. One was taken from a patient with her side consent, but this patient has features that are classic for 22q11 deletion syndrome. These the middle picture are the like cone-shaped teeth that you might see in Nemo. The third picture is a teenager who just never really lost a lot of her baby teeth. And that is a very unique, interesting feature that can be suggestive of autosomal dominant hyper IgE syndrome, which we really now call STAT3 loss of function. This is a serious nail infection. Onychomycosis is what we call it. This silvery hair is something you will see in Chediak Kakashi, and that's what the hair might look like under a microscope. So physical exam is still really, really important, not just labs, in diagnosing a potential immune deficiency. So I feel like I'm already using a lot of time, so I'm going to try to speed things up. But now I've broken down the immune system. And so these are different just representations of diseases that represent defects in B cells, T cells, defects, phagocytes, and complement that your humoral immunity. That's you make antibodies, and so these kind of infections happen when you have low antibody production. The T cells, bacterial, viral, fungal. T cells actually very, very, very low CD4 T cells can lead to pretty significant viral, fungal, bacterial infections that are hard to control, but also can lead to something called opportunistic infections, and that's what pneumocystis jirovecii is. And what that means is that these organisms are opportunistic, so they're not good at infecting people. They're pretty bad at it. So they are taking advantage of the opportunity to flourish and grow if your immune system isn't good enough to suppress them. So these are not common infections. These are infections that if you had pneumocystis, your physician would probably say you must have a compromised immune system until proven otherwise. So a lot of these viruses will make you think of T cell issues. You can have chronic diarrhea, failure to thrive, respiratory infections. When I think of phagocytic disorders, actually, that's where I think of the skin abscesses, not really in B cells. So I'm sorry that I copy forward the slide and it says that, but really for skin abscesses, I'm usually thinking something's wrong with your neutrophils. having really significant gingivitis can be a feature of phagocytic disorders, or wounds that don't heal very well can be another feature. And then complement, we already talked about a little bit. So when your innate immune system goes wrong, you can have a defect in the number. So there's certain immune deficiencies where you will have a decrease in the number of neutrophils, and we call that neutropenia, where you don't make them, or you don't make them in good numbers. There's also defects where you make the neutrophils and phagocytes, but they don't work very well. And so cystic fibrosis, interestingly enough, is listed, even though that's not a gene defect that affects your immune system. Cystic fibrosis is recognized as something that might affect your function of your phagocytes, leading to infection. There's also defects that can cause something called leukocyte adhesion deficiency, where your neutrophils are in your bloodstream and they're ready to go. And then what happens is they need to leave your bloodstream and go into your tissue to fight that infection, but they can't. So they're missing sort of like the markers on their surfaces that help them leave your blood vessel. So actually what's interesting in leukocyte adhesion deficiency, on all pediatric boards, one of the things that they say is that the umbilical stump doesn't fall off. So we will get referrals where an umbilical stump on a newborn baby takes about a month to fall off. The majority of them are overzealous cleaning with alcohol wipes and not LAD, but we do sometimes will get a CBC and look, because these patients can have actually high number of neutrophils. They just can't escape to do their job. GATA2, CGD, just going to try to move things a little bit faster. Innate cell signaling defects, so toll-like receptor defects, IRAK4, MyD88, TLR3, these are all rare, but they can early in life, right? Because early in life, your adaptive acquired immune system isn't that great. So these patients can present very early with very serious invasive bacterial infections, because like we talked about, your innate immune system works quickly. But then as you get older, if you survive this period, your adaptive immune system seems to really help, and they do better. So one CGD, chronic granulomatous disease, is one of the more well-known innate immune system defects. And it's the most there's multiple defects that can cause CGD, but the most common is X-linked. These children are mostly diagnosed by age 5, not always, but they do have poor growth. They can have big lymph nodes. One of the earliest things they have is big lymph nodes, actually. It can be a presenting feature. But what's interesting about this defect is that these neutrophils have a specific defect in making what we call an oxidative burst. And oxidative burst is important in these specific, there's a couple more that are even more rare, but in terms of common, these specific organisms actually, you need a really good neutrophil oxidative burst apparently to get rid of them. And so this is what ends up infecting a lot of these patients, especially they have a lot of difficulty with staph and aspergillus. And so treatment now with itraconazole and Bactrim really helps prevent a lot of infection. We can also sometimes add an interferon gamma. And these patients can get transplanted. The earlier they get transplanted, the better they do and the better the outcome. And what's super exciting is that there's gene therapy that's coming in the future. So antibody deficiency or defects in the humoral immunity. And that's where you don't make antibodies or they don't work right. And so you get more what we call sinopulmonary infections, is exactly what it sounds like. Sinus, ear. If you come to my office and your issues are sinus infections, ear infections, and pneumonias, this is where our mind goes to, is a humoral defect. And so these are often with the bacteria that causes the sinus and well-described immunodeficiency. And it was called Bruton's because Colonel Ogden Bruton is really the first one to describe it in 1952. I think it's just so interesting that 1950, that feels so recent. is when we really describe the first like genetic inborn error of immunity. But it wasn't even until 1993 that they really realized that they really nailed down the gene defect that causes it. But these are boys who have complete absent B cells. And so early on in life, they'll have a lot of, they'll get pneumonias, they'll get a ton of ear infections until it ends up being recognized and diagnosed. And when you do the CBC and you look at the lymphocyte subsets, they will have no B cells. The other thing about them, I think, is interesting. They have no B cells, so they don't make antibodies. So they completely lack antibodies. And they don't have tonsils, because the tonsils are where your B cells kind of help work with antigen presenting cells to just kind of, that's where they like really they do their job, and they're absent. So when you look in their mouth, they actually don't have tonsils. So when I do my physical exams on patients, I usually, if they don't have tonsils, I write tonsils surgically absent if they've had their tonsils removed, so that I know that they had them at one point. And these patients are going to need immunoglobulin replacement for their entire life. So common variable immunodeficiency was first reported in 1953, but its average age of onset is 25. But usually we say the diagnosis around over the age of 4. Under the age of 4, we really say you should be looking for something else too. Like maybe you need some genetic testing because you just don't want to call it just CVID. CVID diagnosis officially is made with 2 immunoglobulins that are low. So we can't just have low IgG technically to have CVID. You really have to have low IgG plus low IgM or low IgA. And you have to have an abnormal response to antibodies. This still remains a clinical diagnosis. So you don't have to have a positive genetic test to have CVID. What's interesting is I feel like 15 years ago, 10% of CVID patients actually had a genetic diagnosis. And now a third of patients, if you look, might have a genetic diagnosis. But that still means 2/3 of patients will have CVID even when the genetic testing doesn't identify a single gene defect. So this is still something that can be made, that can be diagnosed clinically. The other thing is that they can have a lot more autoimmune diseases than the general population, and they are, compared to the general population, at a higher increased risk for malignancy. And so the treatments, you really want to just help prevent infection. They also will need immunoglobulin replacement. Sometimes we do prophylactic antibiotics. I still give my patients the flu shot. I think that they might help. They don't always help everyone, but they might help. And that's the immunoglobulin replacement that you get is not going to have a lot of protection against the flu because it's just different every year. And these patients are closely followed. Selective IgA deficiency, I feel like I am taking a lot of time. Selective IgA deficiency is actually the most common antibody deficiency. What's interesting is we don't have a gene that causes IgA deficiency. I think the other interesting thing too is that sometimes we get referrals for IgA deficiency, not because they got sick, but because they were checked for celiac. And part of the workup for celiac is you have to have an IgA against gluten. And so if you don't make IgA, then you can't get diagnosed with celiac that way. So they check an IgA as well. And some of these patients with no infectious history will actually have no IgA. So it's not always that you get infections, but when you do, they are the sinopulmonary infections, because that's what we talked about antibodies are helpful for. So they can get sinus, ear infections, they can get pneumonias. What's also interesting is that it's actually strongly associated with allergy. I think the most interesting allergic thing I saw with selective IgA deficiency is a girl who was eating a poppy seed bagel, and one poppy seed, which is not a common allergy. I think she might be my only patient with poppy seed allergy, and I have many patients with food allergies. One poppy seed allergy flew in her eye, and her entire eye swelled up. I thought that was unusual. I checked her blood for IgE against poppy seed, the one and only time I've ever done that. It was higher than measurable, greater than 100. And that patient also had an IgA deficiency. So I thought that was really interesting. And they also can have an increased frequency of autoimmune disorders. So they're supposed to wear medic alert bracelet due to the possibility of anaphylaxis with blood products. Although honestly, I think that that's seeming to be really, really, really rare. But we don't really put them on immunoglobulin replacement because immunoglobulin replacement like IVIG and all the sub-Qs that are out don't replace IgA. The other thing is if I have someone with an Ig deficiency, I take a good history, I do a good physical, because if they have anything that's a little suspicious, I know that Ig deficiency sometimes can be a part of another immune deficiency. Actually, many immune deficiencies, you might just have an Ig deficiency as a part of something else. So you really have to, a little more controversial. I think where you make the normal amount of antibodies, but you don't have a good response specifically to the pneumonia vaccines, the polysaccharide vaccines. These patients do seem to get more sinus infections, and a lot of the literature is focused on the sinus infections that they get. And then this, I'm going to just go quickly because I feel like I put in a lot of diseases and I don't have a lot of time, but I just want to talk about hyper IgE syndrome, which used to be called Job syndrome. So you might have heard it from that way. But that is, interestingly, that's from this quote from the Bible. But now it's called hyper IgE syndrome. And this is not one gene, it's a bunch of genes. That can cause you to have elevated IgE, but they also can have staph skin abscesses, pneumonias. They can get really bad, what looks on an x-ray like what we call pneumatoceles, where it looks like just this big, almost bubble where where you had a previous pneumonia. The autosomal dominant is now, we know, which we didn't know before when it was described, is due to a loss of function mutation in a certain gene called STAT3. This is important in the development of T helper 17 cells. And these patients also can get a lot of allergy symptoms. Eczema, their IgEs are typically really high. They can actually sometimes have normal IgE, so they don't always 100% have to have an elevated IgE. But they have these retained primary teeth. I don't know of any other immune deficiency where you just don't lose your baby teeth. This is like the only one I could think of. And they really can get fractures so easily. One of my patients had a fracture because she was standing on a beach and the wave hit her leg so hard that she just scooted and fell on her butt and she broke her leg from that. So they're really prone to getting fractures. There is an autosomal recessive form, and that's a little bit different. It's a different gene as well. But these patients typically require prophylaxis to prevent infections. And sometimes, not all of them, but some of the patients still have to get managed for their eczema that can remain significant. Some of my patients with this have significant asthma. And there are case reports of other treatments. And then just to talk a little bit about SCID, I think everyone knows about severe combined immunodeficiency, but this is a photo of David Vetter. He was known as the bubble boy. He had X-linked SCID, and it was diagnosed because his brother had died of SCID. So when he was born, they actually put him right in the bubble straight from birth. And finally, after living like this until the age of 12, they finally decided that they have to try something. You can't live like this forever. But unfortunately, after his transplant, he had EBV and complications and passed away. So what is SCID? SCID is really what it sounds like. It's severe combined. It's where all patients with SCID will have significant T cell defects. So either they have almost no T cells or they have almost no working T cells. And if you have almost no working T cells, your B cells might be there, but they're not going to work because your B cells need the T cells to tell them what to do. So that's why it's combined. And they can have all of the signs of both a T cell and a B cell defect. And what's important is that it has to get recognized early because it is fatal without treatment. You would think that if you don't have T cells and B cells, you're going to present right at birth, but you don't. Why is that? I mean, we talked about the innate immune system can fight infection, but also you have IgG from your mother for the first 2-3 months of life. So these patients would typically present with a very serious infection after the age of 3 months. And they also don't have a thymus. And this is a slide I actually used to educate a physician. So, but the treatment is Dr. Buckley, who is just a goddess in the field. She did these studies where she found that if you get a bone marrow transplant under the age of 3.5 months of life, that your chance of living is really high. And that's because you're getting transplanted before you present with significant illness. And it's so the treatment is going to be a bone marrow transplant, but now we do have gene therapy coming up, which is super exciting as a form of treatment. I'm going to go really fast over DeGeorge, which is what we call 22q11.2 deletions. And these patients have low absent T cells, but it's very rare for you to have complete DeGeorge, meaning no T cells. Those patients present looking like SCID, right? Because if you don't have T cells, you don't have B cells, but you don't have functional B cells. But the majority of patients have T cells, they're just low. And so they do make B cells and they do make antibody. So if you have complete DeGeorge, you need a thymus transplant. Right now, it's only done at Duke, but it is actually coming out now as a therapy that will soon hopefully be offered at other institutions. And so what is the future of primary immunodeficiency? So it's different from this talk about immune system issues. So we have a patient who first few years of life, he had AOM, which is just otitis media, so ear infections. But then he came in at the age of 6, devastatingly ill with pneumonia. He had inflammation around his heart, and they noticed that he had a big spleen. He had severe anemia. They actually diagnosed him with spherocytosis at the time. He ended up getting ear tubes. He had to get sinus surgeries. He was getting a lot of sinus and ear infections. Interestingly, his IgG at that time was normal, but his IgM was really high. So this is just indicative of some sort of dysregulation in his immune system. And his T cells were super low. But this was a while ago, so people weren't really sure what he had at the time, but he just continued to get pneumonia after pneumonia until the point where he got bronchiectasis. So that's a word where your, I guess, the breathing tubes or bronchioles in your lung, when you get a lot of infection, they actually kind of can stretch out a little bit. So they end up trapping a lot of mucus. And so it predisposes you to getting even more lung infections. And it happens from previous infections. So he ended up having bronchiectasis. And he was starting to see pulmonology, was started on IVIG at the time because he was put on Bactrim just because his T cells were so low. We were trying to prevent infection. And then he came in, and now this time he just had big, huge lymph nodes. He still had a big spleen. He had a big liver. So that's immune dysregulation. So what's so different about him? He was actually called CVID. And then originally someone diagnosed him with hyper IgM. He can't have hyper IgM. Hyper IgM means that IgM is the first antibody you make, right? So after all of us make IgM, when we see an infection, we switch. It's called class switching to IgG or IgA. Hyper IgM means you can make IgM, but then you can't make IgA. IgG, you can't switch. He made IgG. He made totally normal IgG. He technically cannot have hyper IgM. So I knew that was wrong. The low complement is not a classic feature of CVID. He had a very low T cells. That's not typical for CVID. In fact, if someone comes to me with a CVID diagnosis and they have low T cells, I will guarantee genetic test them because I worry that we're dealing with something else here that's treated differently. Once he got put on IVIG, he didn't have any more pneumonias, but he was still having evidence of immune dysregulation. So we sent for what's called whole exome sequencing, and this is an amazing tool that we have now where you can look at all of the genes in a patient that all the exomes, so the genes that encode for proteins, not the parts of the genes that we call introns that don't specifically make the proteins, but you can look at thousands of genes this way. And that's how we ended up getting a diagnosis. So he had a P110 delta activating mutation. This was causing his T cells to be overactivated until they just became exhausted. They were just quiescent, senescent. And this overactivation of his immune system was giving him a big spleen, giving him big lymph nodes. And this is due to the P110 delta, it's a subunit of PI3 kinase. The reason I'm telling you that and why it's important is because there is literally a treatment that's a PI3 kinase inhibitor that's called linezolid. I always pronounce that incorrectly. But because of this diagnosis, we actually enrolled him in a study for a PI3 kinase inhibitor. He took a pill twice a day. His spleen shrunk. He was able to walk and talk in full sentences and was exercising. He was actually playing a lot of Pokemon Go for multiple hours a day. And his entire life was changed by this pill that he was on, which was made possible because of the genetic testing and figuring out a precise diagnosis for him. And so that's why I think this genetic testing is amazing, because this is precision medicine, right? So we used to only say, well, we're going to give you some immunoglobulins. And if it's really bad and it's your T cells, then we're going to just have to give you a whole new immune system through a transplant. Or if your immune system's a little overactive and wacky, we're going to have to give you steroids and rituximab. But those aren't really specific. And now we have precision medicine. So if you have herpes simplex encephalitis caused by HSV, you can get interferon alpha or beta therapy. You have CGD, you can get interferon gamma therapy. You have a gain of function STAT3 mutation that causes a lot of autoimmunity. You can get tocilizumab. That's targeted therapy to help combat this specific mutation. And look at how incredible these therapies are. So this patient with gain of function STAT3 mutations had really significant arthritis. And look after therapy, start of therapy, 1 year after therapy, look at the hand and the difference in the hand. That is from a medication with much less toxicity than the other kind of medications that we have without precision therapies. Our patients with CTLA-4, when we have with a lot of different if you have multiple autoimmune syndrome, if you have multiple autoimmune issues, you're going to get a better receptor because that's a CTLA-4 agonist. It literally is targeted towards what the genetic defect does to you. And so STAT1 gain of function, you can use a JAK inhibitor, and this published picture, even this JAK inhibitor caused her hair to grow back. And my patient with CTLA-4 haploinsufficient, one of them, also lost almost all of her hair. And I had a discussion with the rheumatologist about starting her on a beta sept. And I said, I think her hair is going to grow back. And the rheumatologist uses a lot of beta sept for other diseases and said, oh, no, we don't, that's not what happens. And I was like, oh, wait, just you wait and see, because this is for CTLA-4. This isn't for JIA. And she grew all of her hair back on the beta sept. So that's really, to me, what tells me that if we need to have a precise diagnosis, because we have precise medicine now that can help people. So for IPEX, for APDS, the rapamycin, that's the APDS is what that teenager, I guess he's now a grown man, had, who ended up on the PI3 kinase inhibitor. And then X-Men, I always find so interesting because it's treated with magnesium. These are boys who get really bad EBV infections, and the treatment is just something as simple as magnesium. So I do think I went way over time, and I'm sorry. And I thank everyone for their patience and their attention. And I'm happy to take questions.
Oh my goodness, Dr. Chong, you are amazing. Thank you for sharing such wonderful information with us. And I must say, having been involved in the PI community for about 25 years, I learned a lot tonight. I always do.
Okay.
So thank you. Now, at this time, I would like to invite my colleague, Stephanie Steele, Community Engagement Manager, to moderate the Q&A session. And then she is going to wrap up the evening for us by wishing everyone a wonderful rest of the night. So Stephanie, take it away with the Q&A.
Thank you, Kathy. As Kathy said, I am Stephanie Steele, the PI Community Engagement Manager. Dr. Chong, we have some great questions for you. We're going to start off with, you have said that the future is in genetic therapy, or I'm sorry, gene therapy. Can you explain that in greater detail for us, please?
Yes. So now that we know in many of these diseases exactly what gene is not right, you can literally take that patient's cells and give them the correct gene and give them their own cells back. It's safer than the way we do things right now. And it's being studied already for CGD, for SCID. So I do actually think that when it really becomes widely available, that it is going to be something that is highly considered, even first, if not at the same time as you would do bone marrow transplant, because of its really, really good safety profile.
Good to hear. How often would you order genetic testing as opposed to just a regular blood test for IgG levels or pneumococcal titers, things like that?
So I usually start with the immune workup first, right? So patients who come, so for our clinic, most of our patients have to be referred in from another physician. And so someone's already suspicious that something is wrong, but they haven't done the workup. So I almost always start with a good history. I like to hear about what happened when you were little. And I generally start with a very good, thorough immune workup first. So I want to know your antibodies. I want to look at your T cells. I want to look at your B cells, NK cells. And part of that workup is often tailored to what you tell me, right? So if you're already 25 and you just have really significant sinus infections that are very difficult to treat, you've had pneumonia, ear infections, and that's it. That's really what you've had. Then I know you don't have SCID, right? Because you're already 25, you're not having a T cell problem. Then I'm really going to focus on the B cell problem. And also just the blood work sometimes can help me make a diagnosis even before the genetic testing comes back, because that usually takes the longest to come back. That takes way longer than any of the immune cells. So the patient who came with a big spleen, whose dad had a big spleen, whose granddad had a big spleen, I was able to order just a blood work looking at what's called double negative T cells. And they had a high level that's just done by flow cytometry, and they had a high number of double negative T cells. And so instead of doing a huge genetic panel, I just said, I just want this gene. It's just these couple genes. Just give me those couple genes. Give me an answer quickly, because I can make that diagnosis so fast. If I am highly suspicious, I mean, there's 450, 500 genes. I don't have the memorized. So if I can't, then I'll just go to a whole exome sequencing, which means I'm casting a wide net. I'm looking at a lot of genes, because you might have something that presents differently. I can't tell you how many times that we see something that nobody else with that gene defect had before, right? Even for the patient with ICF2 syndrome, nobody else had what she had with ICF2 syndrome. So even if I'd looked for that, I wouldn't have seen it because it hadn't been described to be that way. So sometimes you just really need to do a huge gene panel. And it's always a discussion with the parent. Sometimes the parents and the family, I take care of mostly kids. So sometimes the parents don't want it. And if I think, well, I'm a little worried, but my suspicion isn't really high, then I don't push really hard for it. But sometimes I think my suspicion is high, and I even know that this will change their therapy. And then that's a discussion where I might have more than once and twice or 3 times. And a lot of it is you just really have to, these are patients who have been shuffled from doctor to doctor to doctor sometimes, right? And so they a lot of it is building a relationship with somebody who trusts them, believes them, knows that this is unusual, right? And so sometimes it takes a couple visits where I say, listen, I really think that this might be a way to go. So it's very individualized. I can't just say who's going to immediately get genetic testing, who's always going to get it, who doesn't get it. It's just case by case.
Absolutely. Our next question. I've heard that certain blood tests are affected by IG therapy. Is this true? And then what is done to have certain tests checked appropriately?
So when you get immunoglobulins, then I can't check your response to your vaccines. I can't check, and this is something I always have to remind other docs too. So you can't check antibody responses to anything. So I can't tell. Some of our workup for your immune system, like for the diagnosis of CVID, for instance, we look at responses to your tetanus vaccine, right? So I look for tetanus titers. And when I use the word titers, you probably have all heard the word titers. That's just another word for antibody levels or another word for immunoglobulins, right? So when I'm looking for these titers, but you're on immunoglobulin replacement, that could just be from the immunoglobulin. It's not going to give me an indication of your response to tetanus. So a lot of times our hospital, Children's Hospital Pittsburgh, they know if they have a suspicion for immune deficiency, they'll ask us to see the patient first, order our labs, and then do the therapies later that day so that we can get all of our testing that we want.
Are there certain diagnoses where IG therapy would not be needed lifelong?
For me, transient hypogam of infancy. Sometimes I try, if you're really, really young, it might take you a while to make some IgG. Some of those patients do go on immunoglobulin, and they get followed, and the hope is that they can come right off of it. But one of the things about CVID is that the vast majority of people I know, once I start it, once you need it, I'm probably not gonna stop it. So sometimes when we find people really early and they're not getting really sick and their IgGs aren't really that low, sometimes we'll just watch and try to give them some time before they start it. But most of the people who I see who are just temporarily on immunoglobulin are those who have it not primary, and that's the difference. They have it secondary. So they had rituximab for an autoimmune issue, and then they, for some reason, they weren't able to make good cells, or some other secondary cause. Uh-oh, is this frozen?
Can you hear me okay?
I can. Were you able to hear me, or was I very frozen?
We could hear you.
Okay.
Okay. How does an immune deficiency turn into cancer?
Really good question. And I wish I knew the answer to that, truly, because then we could prevent it from happening. But I don't really think that any of us are really able to say who with CVID is going to get cancer, who with XIP is going to get cancer. I don't think we're able to figure that out, but that would really be an area of interest.
Can you tell us what the correlation is between CVID and liver disease?
Oh, so CVID is definitely correlated with the potential to have liver disease. I don't know what you mean by like correlation, like why exactly does it cause liver disease? I'm not really sure exactly why some patients with CVID can get liver disease, but we do know, so we do suspect when they have certain, especially autoimmune liver disease, not just any liver disease, but specifically certain autoimmune liver diseases, that it is a direct result of the dysregulation in the immune system. So patients with CVID, not only is your immune system low, but some patients with CVID can have what's just really dysregulated immune system. And that's where the autoimmunity comes from. And that can also contribute to the possibility of having the liver disease.
Thank you. Can you explain the relationship and prevalence between PI and chronic fatigue?
You know, I don't know the data on PI and chronic fatigue, but that is definitely something that I hear a lot from patients. And what's really interesting, because I don't know if there is even data on this, what I find very interesting is that not only does immunoglobulin replacement often prevent infections, but for a lot of my patients, I hear that it actually gives them energy. It gives them their energy back. I find that really interesting. I don't have a clear understanding why, but whoever this person is that asked me this question, I would love if they know or have any data on this, because it is true. It is something that I hear and I see a lot.
Absolutely. Our next question, can you explain how our GI system or gastrointestinal system assists in our immunity?
Oh, yes, absolutely. Your GI system is so important. I mean, you have those pirate patches, you have a lot of B cells activity in there. The immune system, you have a lot of mucus in there protecting your immune system. So the immune system is a really, really important immune organ. And so a lot of your immune system is found locally throughout your GI tract, actually. I don't know if there was something specific about the gut that they were looking for, but yes, you can have locally produced B cells specifically in your gut.
Thank you. Our next question, do hyper levels of complementary proteins affect the immune system?
You know, there's a lot of knowledge and information about low complement, but I don't know of any particular immune deficiencies with high complement. We do think that complement can be elevated as just like any inflammatory marker will be elevated. So just like we talked about earlier, that platelet sometimes can get very high as just a marker of inflammation, and that could also be true for complement. But I don't know of any specific immune disorders where just your complement is high or really much higher.
Thank you for that. Finally, so other than HIV, what are other possible causes of low CD4 counts ranging from 2 to 300?
So there's so many immune deficiencies that can cause that, so many. And that's really why if you have CVID, and that's one thing I want to really say to everyone, if you have CVID and you should have had your T cells and B cells and NK cells checked by your immunologist at some point. They really should have done that. There's just no question to me that you have to have that done. And if your T cells are low, in my medical opinion, you deserve further workup. You should not just be called CVID. You should be part of the 30% that has something that's being called CVID. Because I can't tell you one thing. I can tell you, just like that case I described today, they were called CVID with low T cells. They ended up having activated PI3 kinase syndrome, right? So there's so many other genetic causes of low T cells, so many.
Thank you very much. At this point, we're going to wrap up our Q&A. We apologize if your questions were not addressed this evening. If you do have general questions, please do not hesitate to reach out to our Ask IDF box. If your question is specific to your diagnosis or health condition, please contact your physician for an answer since they know your health history best. Dr. Chong, thank you so much for volunteering your time this evening. The information was so valuable and we cannot thank you enough. Jory, we thank you so much. We are so happy to have you. It's wonderful to meet you. Everyone is so excited to get to know you, and we're so excited for the future of IDF and to have you as our leader. So we thank you for joining us as well. Yes, so again, thank you for joining us. And remember, IDF is here with you every step of your journey. I hope you have a good night.